Okay, welcome back to part two. So you have taken care of your patient preoperatively, they've had surgery, and now we're going to look at the nursing management of postoperative care. So this is a longer lecture, so I advise you to stop halfway through to take a break and then resume. So the postoperative period begins immediately after surgery and continues until the patient is discharged from medical care. The postoperative care in the PACU, so the PACU is the post-anesthesia care unit or the recovery room. So the patient's immediate recovery period occurs in the PACU. It's located adjacent to the operating room to minimize the transport distance of the patient after surgery and to provide ready access to surgical and anesthesia personnel. So the client's immediate recovery period is supervised by a PACU nurse. Care in the PACU includes monitoring and management of respiratory and circulatory function, pain, temperature, and the surgical site, and assessing the patient's response to the reversal of anesthetic. Assessment begins with an evaluation of the airway, breathing, and circulation. And any evidence of respiratory compromise requires prompt intervention. So you're looking at airway patency, the rate and quality of respirations, you're auscultating the breath sounds, all those things of the ABC. Pulse oximetry monitoring is initiated on admission because it provides a non-invasive means of assessing the adequacy of oxygen. Patients typically will have oxygen. It helps with removing the anesthetic agent because you breathe off the anesthetic agent, and it meets the increased O2 demands from blood loss or increased metabolism. An ECG monitoring may be initiated to determine cardiac rate and rhythm. A slight drop in postoperative blood pressure with a normal pulse and warm, dry skin indicates a normal response to the residual effects of anesthesia and requires only ongoing monitoring. Hypotension, though, with tachycardia and or cool, clammy skin would suggest hypovolemic or hemorrhagic shock and the need for notification of the anesthetist to probably increase fluids and probably increase oxygen administration. So you're constantly assessing the temperature, skin color, and condition. The initial neurological assessment focuses on level of consciousness, orientation, sensory and motor status, and size, equality, and reactivity of the pupils. Sensory and motor blockade may be present in clients who've had regional anesthetic. So you may find some change, or you may find that those areas, the sensory and motor status, may be diminished. Assessment of the urinary assessment by looking at in and outs and fluid balance, and then assessing the surgical site and noting the amount and type of drainage. It's important to explain all activities from the admission, as hearing is the first sense to return. And so it's very important that you explain everything that's going on. Oftentimes you need to orientate the patient and say that the surgery is over, that you're in the PACU unit, that we've notified a family or friend, and who you are that's caring for the client. So what are some of the potential complications? So in the immediate post-anesthesia period, the most common causes of airway compromise include obstruction, hypoxemia, and hypoventilation. So these are potential So we're going by system here. So we're looking at respiratory system. Patients at risk are those who have had a general anesthetic, are older, have a smoking history or lung disease, are obese, or who have undergone airway, thoracic, or abdominal surgery. Airway obstruction is blockage of the airway. It's most commonly caused by the patient's tongue. And it's also caused by being in a supine position, so the tongue falls to the back of the throat. The patient is coming out of anesthesia, so they're extremely sleepy. There may be laryngospasm from having the ET tube removed, the endotracheal tube removed. There could be retained secretions and laryngeal edema, again from the endotracheal tube. Hypoxemia is a PO2 less than 60 milligrams per mercury, and it's characterized by some non-specific clinical signs and symptoms ranging from agitation to somnolence, meaning very drowsy, very hard to arouse, hypertension to hypotension, and tachycardia to bradycardia. An arterial blood gas is used to confirm if the pulse oximetry is low. So typically it will be an O2 saturation under 90%. The most common cause of postoperative hypoxemia is atelectasis, which is a complete or partial collapse of a lung or segment of a lung that occurs when the alveoli become deflated, which may be the result of bronchial obstruction caused by retained secretions or decreased respiratory excursion, so the decreased expansion of the lungs. This is a diagram of postoperative atelectasis. So in A, right here, we have the normal bronchiole and alveoli. In B, we have the mucus plugs in the bronchioles. And in C, we have collapse of the alveoli by atelectasis following absorption of air. Other causes include pulmonary edema, which is caused by accumulation of fluid in the alveoli. It can result from fluid overload, left ventricular failure, or prolonged airway obstruction, sepsis, or aspiration. It's characterized by hypoxemia, crackles when you listen to the lungs, decreased air compliance or decreased compliance, or infiltrates on X-ray. Pulmonary embolism is a blood clot that occurs in the lungs. It can damage part of the lung due to restricted blood flow, a decrease in oxygen levels in the blood, and affects other organs as well. Large or multiple blood clots can be fatal. The blockage can be life-threatening. Aspiration of gastric contents. Clients at risk may be pre-medicated with histamine H2 receptor antagonists like Zantac or ranitidine before induction of anesthesia to prevent HCl secretions. And that's why we always want to ensure our patients are MPO for the right amount of time. And bronchospasm results from an increase in bronchial smooth muscle tone with resultant closure of small airways. And in these cases, edema develops, causing secretions to build up. And signs and symptoms would be wheezing, dyspnea, use of accessory muscles, hypoxemia, and tachycardia, or an increased respiratory rate. Hypoventilation is characterized by decreased respiratory rate or effort, hypoxemia, and an increasing arterial partial pressure of CO2, known as hypercapnia. So, assessment related or nursing management related to respiratory complications. The nurse evaluates airway patency, chest symmetry, and the depth and character of respirations. The chest wall is observed for symmetry of movement with a hand placed lightly over the xiphoid process. Breath sounds are auscultated anteriorly, laterally, and posteriorly. Regular monitoring of vital signs and the use of pulse oximetry in conjunction with a thorough respiratory assessment are early for early recognition of respiratory problems. And it's important to note the characteristics of sputum. Proper positioning facilitates respiration and protects the airway. Unless contraindicated by the surgical procedure, the unconscious patient is positioned in the lateral recovery position, which keeps the airway open and reduces the risk of aspiration if vomiting occurs. Oxygen therapy will be used if the patient has had general anesthesia and/or the anesthetist orders it. What about on the clinical unit? Well, the common causes of respiratory problems are atelectasis and pneumonia, especially if the patient has had abdominal or thoracic surgery. And that's related to mucus plugs and decreased surfactant, hypoventilation, a recumbent position, ineffective coughing, and/or smoking. So what can you do on the clinical unit? Well, deep breathing and coughing is extremely important. So deep breathing is encouraged to facilitate gas exchange, and the patient should be assisted to breathe deeply 10 times every hour while awake. And so it helps prevent alveolar collapse. It helps move the respiratory secretions to the larger airways for be able to be expectorate. The respiratory therapist or the physiotherapist will encourage clients to deep breathe, 3 to 4 deep breaths every 5 to 10 minutes. Using a centum and spirometer is also very important, and splinting of the abdominal incision provides support to the incision and aids in coughing. Again, on the clinical unit, the patient's position should be changed every 1 to 2 hours to allow full chest expansion and to increase perfusion of both lungs. Ambulation, not just sitting in a chair, should be aggressively carried out unless contraindicated by the surgical procedure performed or other concurrent diagnoses. What about potential alterations in the cardiovascular function? Well, the most common problems associated with the cardiovascular system include hypotension, hypertension, and dysrhythmias. Patients at greatest risk include those with alterations in respiratory function, a history of cardiovascular disease, older adults, and debilitated or critically ill patients. Hypotension is most commonly caused by unreplaced fluid and blood loss, which may lead to hypovolemic shock. Other causes include dysrhythmias, decreased low systemic vascular resistance, and maybe having an incorrect cuff placed on the patient, maybe the wrong size. Treatment of hypotension begins with oxygen therapy to promote oxygenation of hypoperfused organs and fluid and blood replacement. Hypertension is most frequently the result of sympathetic nervous stimulation that may be the result of pain, anxiety, bladder distension, or respiratory compromise. Treatment of hypertension will center on addressing the cause of the sympathetic nervous system stimulation and eliminating that cause. Treatment of hypertension, it may result also from hypothermia or pre-existing hypertension. It may be the result as seen after revascularizations during surgery. So if you're going for a bypass surgery and the vessel that was bypassed, it may be the result of an improved perfusion after surgery into those coronary arteries. Dysrhythmias are often the result of hypokalemia, hypoxemia, hypercarbia, so an increased PCO2, alterations in acid-base status, circulatory instability, and pre-existing heart disease. Other causes could be hypothermia, pain, surgical stress, and anesthetic agents. So lots of things can cause dysrhythmias. And treatment is directed towards eliminating the cause. So when the patient is in the PACU nurse will be completing vital signs every 15 minutes or until the patient is stable. And then it's important to notify the anesthetist or the surgeon if the systolic blood pressure is below 90 or greater than 160, or if the blood pressure decreases during several consecutive readings. You might be thinking hemorrhage. If the heart rate is less than 60 or greater than 90, if there's an irregular cardiac rhythm, or really any significant variation from pre-op readings. And this is the importance of the nurse preoperatively writing those pre-op baseline vital signs on the chart. In the postoperative unit, if we look at cardiovascular system, the postoperative fluid and electrolyte imbalances are contributing factors to alterations in cardiovascular function. Fluid overload may occur when IV fluids are administered too rapidly, when chronic, such as cardiac or renal disease exists, or when the patient is an older adult. Fluid deficit may result from inadequate fluid replacement, and you'll get decreased cardiac output and tissue perfusion. Hypokalemia causes dysrhythmias, and it can be a consequence of urinary and GI tract losses and inadequate potassium replacement. So remember that hypokalemia directly affects the contractility of the heart. Syncope or fainting may occur as a result of decreased cardiac output, fluid deficits, or deficits in cerebral perfusion. And it frequently occurs from postural hypertension on ambulation. And so, this is very common postoperatively, and that's why it's very important to have patients rise slowly out of bed, and also to do sitting, standing, and lying supine blood pressures to see if a patient is going to have any postural hypertension. So when you find that a patient does have postural hypertension with that dropping of blood pressure as the patient sits up, that's a clear indication of hypovolemia. So how do you manage the cardiovascular problems in the clinical setting? Well, an accurate in and output record should be kept during the postoperative period. You're going to be monitoring laboratory findings such as your CBC and your electrolytes. You're going to be assessing the infusion rate of the fluid replacement in the infusion site, adequate mouth care. You'll be assessing the apical radial pulse carefully and reporting any irregularities. And you're going to be assessing the skin color, temperature, and moisture. Deep vein thrombosis may form in leg veins as a result of inactivity, body position, and pressure, all of which lead to venous stasis and decreased perfusion. Patients should alternatively flex and extend all joints 10 to 12 times every 1 to 2 hours while awake. Early ambulation is the most significant general nursing measure to prevent postoperative complications. It's so important. So with ambulation, you're going to slowly progress. You're going to monitor the pulse and assess for feelings of syncope. Other things after post-op surgery, typically patients will be on unfractionated or low molecular weight heparin in combination with maybe elastic stockings, and they're used to prevent DVTs. What about neurologic function? So in the PACU, you may have delirium, and it can include such symptoms as restlessness, agitation, disorientation, thrashing, and shouting. It may be caused by anesthetic agents, hypoxia, bladder distension, pain, electrolyte abnormalities, presence of the endotracheal tube, polypharmacy. Maybe the patient's had too many drugs. Maybe they've had an anesthetic. Maybe they've had something for nausea. Maybe they've had something for pain. Pre-op dehydration and malnutrition, or the patient's preoperative state of anxiety. So a lot of things that can come into play with postoperative delirium in the PACU. Delayed awakening is most commonly caused by prolonged drug interaction, particularly of opioids, sedatives, and inhalational anesthetics, as opposed to neurological injury. So in the PACU, the PACU nurse is going to be monitoring or assessing the patient's level of consciousness, orientation, and memory, and ability to follow commands, and the size, reactivity, and equality of the pupils are determined. Also the sensory and motor status. The most common cause of postoperative agitation is hypoxemia. And remember, sedation may be beneficial for controlling agitation and providing safety, but that's, again, only if the patient is agitated. But it's more important to find the underlying cause first before you start giving sedation. And then remember safety in the PACU. So until the patient is awake and able to communicate effectively, it is a responsibility of the PACU nurse to act as a patient advocate and to maintain the patient's safety. So side rails up, secure IV lines and any artificial airways, verify the presence of identification and allergy bands, and manage the physiological status. And remember, pain. Pain is a common problem, and remember, it's a significant fear for the patient in the PACU, so giving good pain medication. What about on the clinical unit? So postoperative delirium may arise from a variety of psychological and physiological sources, including fluid and electrolyte imbalances, hypoxemia, drug effects, sleep deprivation, and sensory overload. So to prevent and manage postoperative delirium, the nurse should address factors known to contribute to the condition. The nurse should attempt to limit psychological problems in the postoperative period by providing adequate support for the patient. So what you'll be doing neurologically wise in your assessment, you'll be completing a CNS assessment, ensuring clients receive pain medication, are responsive and oriented to person, place, and time. So when you're giving the pain medication, make sure you know their orientation status and make sure that they aren't confused or they're not very, very drowsy, because you want to ensure that pain medications aren't causing a neurological change. You're always assessing the sensation and motor function on any client who's had a spinal or epidural anesthetic. So pain and discomfort. Pain is a common problem during the postoperative period. Postoperative pain is caused by the interaction of a number of physiological and psychological factors, including surgical trauma to the skin and underlying tissues, patient anxiety and fear, and aggravation of the incision area through the effort and movement associated with deep breathing, coughing, and changing positions. In the PACU, the pain is more related to the immediate post-op period of that surgical manipulation, positioning, mobilization, and any internal devices. Maybe they've got a fixator on their knee or hip. So on the clinical unit, I've already described these different types of reasons for pain. So I've already talked about trauma to the skin and retraction during surgery. There could be muscle spasms around the incision, tension and muscle spasm due to anxiety and fear. This is typically in the neck and the shoulders. It could be related to the importance of us encouraging deep breathing and coughing and changing position, and that's why very good pain management is needed. And the pressure in the internal viscera, so in the internal organs. So maybe there's inflammation or swelling from the type of surgery. So what is your clinical assessment going to look like? Well, you need to identify the location of the pain. Is it incisional pain, which is to be expected, but other causes of pain, such as a full bladder, may be present. Maybe the patient has urinary retention. So observe for the indications of pain, question about the degree and characteristics of pain, and measure pain before and after treatment is administered. So obviously, I don't need to tell you about the behavioral clues. In the PACU, the client may not be able to verbalize, so looking at those behavioral clues of wrinkling up the face or brow, crying, moaning, restlessness, and or increased blood pressure and pulse rate. So in the PACU, you'll be giving IV narcotics. Maybe they have an epidural or a PCA or a regional anesthetic blockade. And so this is a way to provide analgesia, and I'll speak to those in a couple of slides. And then other comfort measures. So touch, family, rewarming, heat or cold application, massage, imagery, music. In the clinical unit, the postoperative pain period, I can't tell you enough or stress enough that postoperative pain relief is one of your biggest nursing responsibilities. During the first 48 hours, narcotic analgesics are required to relieve moderate to severe pain. Afterwards, as soon as you can, it's important to switch to non-narcotic analgesics. And typically you will find that patients will do well on anti-inflammatories. And the most effective interventions include both pharmacological and those non-pharmacological approaches. It's important that the nurse should notify the physician or request a change in order if the analgesic either fails to relieve the pain or makes the patient excessively lethargic. So it's effective pain management is so important for promoting optimal healing. It prevents complications such as atelectasis and DVTs because the patients can deep breathe and cough. They can ambulate. And it allows the client to participate in their recovery activities. And it should be timed to ensure it is effective during painful activities such as ambulation. Before administering the analgesic, the nurse should assess the nature of the client's pain. So again, I don't need to go through this. You know how to do a pain assessment. And so it could be incisional pain, which analgesic administration is appropriate. If it's chest or leg pain, it may indicate a complication. So maybe they're developing a pneumonia, a DVT, and it must be reported and documented. And giving maybe a narcotic could mask that, that pain that they're having. And not that you shouldn't be giving the pain medication, but it needs to be documented that it's not incisional pain. And gas pain could be aggravated by narcotics. And there are a lot of patients that have severe gas pain. And again, the importance of up and walking. So again, I've already talked about the importance of notifying the physician and requesting a change in the order if it fails to relieve the pain or makes the client excessively lethargic. A PCA pump. So patient-controlled analgesia provides immediate analgesia. It maintains a constant steady blood flow of the analgesic agent, and it allows the patient to self-administer a predetermined dose of analgesia by the client. So this relieves the patient's fear and anxiety that they are in control of their pain management. So patients may have this post-surgery. An epidural analgesia is an infusion of pain-relieving medications through a catheter placed into the epidural space surrounding the spinal cord. And it provides for delivery of medication directly to the opioid receptors in the spinal cord. Administration may be intermittent, as through just a bolus, constant, or client-controlled, and is monitored by the nurse. So nursing management, if we look at alterations in temperature, hypothermia, a core temperature less than 36, occurs when heat loss is greater than heat production. Hypothermia may be the result of loss of heat from a warm body to a cold operating room, or loss of heat from exposed body organs to the air or to the use of cold irrigation fluids. Frequent assessment of the patient's temperature in the days after surgery is important to detect patterns of hypothermia or fever, and fever may occur at any time. So as I've said, hypothermia is under the temperature under 36, heat loss exceeds production, and then I've already provided the examples of why that could be happening. Now, individuals who have an increased risk of hypothermia are age, so elderly, and also little ones less than 2 years of age or neonates, long surgical procedures, or prolonged anesthetic administration. So what are the complications of hypothermia? Risk of impaired wound healing, bleeding, cardiac problems, and it may take a while for anesthesia to be removed from the patient's body, so prolonged emergence from anesthesia. Temperature variation provides valuable information about the patient's status. Fever may occur at any time, as I've said. A moderate elevation up to 38 during the first 48 hours usually reflects the surgical stress response. After 48 hours, a moderate to marked elevation higher than 37.7 usually indicates an infection. Infections may include wound, respiratory tract, a urinary tract, IV site, hospital-associated diarrhea, or septicemia. So what is your assessment? Importance of obviously vital signs, assessing the color and temperature of the skin. You'll be doing frequent temperature assessments and observe for early signs of inflammation and infection. In the PACU, it's important to start rewarming the patient. So it could be in the form of passive rewarming, which raises the basal metabolism. So that could be something as simple as removing cold, wet clothing or just moving to a warm environment. And active rewarming requires application of warming devices, blankets, radiant warmers, heated water mattresses. It's important in the PACU to monitor the body temperature at 15-minute intervals. When using any external warming device, you don't want to go the other direction. Skin care is important to prevent injuries, and oxygen therapy for increasing demand. This is as the body's trying to bring up their temperature. And if you're using a rewarming device, this is where you're worried about skin care preventing injuries. It's important to closely monitor the client with an increase in temperature for symptoms of malignant hypothermia, and we spoke about that in the previous class. Symptoms may not be evident until the postoperative phase. In the clinical unit, you'll be measuring the temperature every 4 hours for the first 48 hours postoperatively. You need to be diligent with wound and IV sites when you're doing care. Encourage airway clearance by deep breathing and coughing. Chest x-rays and blood cultures or urine cultures or sputum cultures if you suspect an infection. And antipyretics and body cooling for a fever over 39.4. GI problems. So nausea and vomiting are very common after surgery. So numerous factors have been identified as contributing to the development of postoperative nausea and vomiting. And they include age, gender, female, history of motion sickness, and non-smokers, which is unknown the correlation there. It's also related to the anesthetics or opioids given and duration and type of surgery. So your GI problems, if you're in the PACU, the postoperative nausea and vomiting are treated with the use of antiemetics or prokinetic drugs, so that's getting the gut moving. Oral fluids as tolerated. It's important to have the suction at the bedside in case the patient vomits. Turn the patient's head to the side to protect from aspiration, an upright position, and encouraging slow, deep breathing if the patient's feeling nauseated. In the clinical unit, the nausea and vomiting could be caused by, again, anesthetic agents, but more so opioids. The duration of the surgery, if it's greater than 1 hour, typically people can feel nauseated. Again, the type of surgery. And it's important to avoid NSAIDs because they could be a cause of GI problems. So your nursing assessment for nausea and vomiting. You're going to be asking questions about feeling of nausea. If vomiting does occur, it's important to determine and document the quality, characteristics, and color of the emesis. The abdomen is assessed for distension and the presence of bowel sounds. All 4 quadrants are auscultated to determine the presence, frequency, and characteristics of the sounds. Abdominal distension is caused by decreased peristalsis as a result of handling of the intestine during surgery, limited dietary intake before and after surgery, and it can be prevented or minimized by early and frequent ambulation. It also happens from swallowed air and GI secretions that may accumulate in the colon, producing distension and gas pains. An NG tube may be used to decompress the stomach to prevent nausea, vomiting, and abdominal distension. Or if it's an individual who's consistently nauseated, but more so vomiting, an NG tube will be placed. So normally the stomach motility returns in 1 to 2 days and bowel motility in 3 to 5 days. Now, individuals can develop a postoperative ileus or ileus. And what that is a transient stoppage or cessation of bowel motility that prevents effective passage of intestinal contents and may affect the client's tolerance of oral intake. Typically, the postoperative ileus lasts greater than 3 days. It can lead to a small bowel obstruction if the peristalsis stops. And typically, patients have severe nausea and vomiting because the bowel lumen remains patent, but the contents of the intestine are not propelled forward, producing that severe nausea and vomiting. So how are you going to assess a paralytic ileus or abdominal distension? So again, you're going to be assessing for abdominal distension. You're going to be auscultating the abdomen in all 4 quadrants. And remember that The bowel sounds can be absent or diminished in the immediate postoperative period. So typically what you can do is to figure out if the bowel motility has returned is you can ask the patient if they're passing gas. On the clinical unit, when you're thinking about whether to resume food or not, obviously you need to wait until the return of the gag reflex. Oftentimes there are some orders that the patient remains MPO until return of bowel signs for clients with for clients with abdominal surgery. And so for these individuals, they may be given IV and an NG for decompression. Typically, you start off with clear fluids and advance as tolerated. It's important for regular mouth care when they're MPO, and antiemetics can be administered for nausea and an NG tube if symptoms persist. On the clinical unit, it's important, again, very important, early and frequent ambulation to prevent abdominal distension. It's important to assess regularly for the resumption of normal peristalsis. Encourage the client to expel flatus and explain it is necessary and desirable, and relief of gas pains by frequent ambulation and repositioning. We don't let our patients in the postoperative cardiac surgery unit go home until they've had a bowel movement. So what about urinary function? Postoperative oliguria or low urine output in the first 20 hours after surgery may be expected regardless of fluid intake. So a urinary output of about 30 mils per hour is expected in the PACU. It can be related to a change in aldosterone and ADH from the stress of the surgery, also from fluid restriction, fluid losses during surgery, drainage, or diaphoresis. Low urine output. So anesthesia depresses the nervous system, allowing the bladder to fill more than normally before urge to void is felt. So the bladder can extend more, and so that could just be the result of why there's a low urine output. Also, remember the preoperative drugs that were given? So anticholinergics or opioid drugs may interfere with ability to initiate voiding or emptying or fully emptying the bladder. Urinary retention or acute urinary retention can occur in the postoperative period due to swelling, anesthesia, medications, location of the surgery. And pain may alter perception of the filling bladder as well. So your nursing assessment. The urine of the postoperative patient should be examined for both quantity and quality, also the color, amount, consistency, and odor. Assess indwelling catheters for patency, and most patients urinate within 6 to 8 hours after surgery. If no voiding occurs, the abdominal contour should be inspected and the bladder palpated and percussed for distension. What we typically do in the cardiac surgery unit is check with a bladder scanner. Urine output should at least be 60 mils per hour. If it gets down to 30, that's a significant concern. If the client doesn't have a catheter, as I've said, the client should be able to void 200 mils within the 6 to 8 hours after surgery. Again, if no voiding, you're going to inspect for bladder distension. So how do you help the patient along? Position the client for normal voiding, so having them sit upright. We ensure the client of the ability to void, like you can do this, and use techniques such as running water, drinking water, pouring water over the perineum, ambulation, and use of bedside commode. So surgical wounds. So incisions disrupt the skin barrier and healing and is a major concern during the postoperative period. The incidence of wound sepsis is higher in patients who are malnourished, immunosuppressed, or older, who have a prolonged hospital stay or a lengthy surgical procedure lasting more than 3 hours. And I would also say that wound sepsis is higher in patients on immunosuppressants, which is already here, but more so are diabetic patients. So surgical site infection may result from just an outside flora, so an exogenous flora in the environment or on the skin, endogenous bacteria from within, or a reduced immune capacity. Surgical site infections occur within 30 days after surgery or within 1 year of an implant surgery. Local manifestations include redness, swelling, edema, pain, and tenderness, and systemic manifestations are fever and leukocytosis. Wound assessment requires gathering information through questioning, observation, physical examination, and clinical investigation, and using this information to formulate a wound care plan. In your nursing implementation, you need to note the amount, color, consistency, and odor of the drainage, assess the effect of position changes on drainage. The drainage should change from a sanguinous to a serosanguinous to serous with decreasing output. So that's the normal. And again, make sure the drains are secure and in the correct placement. It is recommended that the physical assessment be done in 3 zones, so the wound bed, the wound edge, and the peri-wound skin. So if I'm looking at this right now, so the wound bed is obviously down the center, and if you can see inside these openings here, the wound edge, again, is the opening of these areas here, and the peri-wound skin is all this redness outside here. So your nursing implementation. So it's important to notify the surgeon of excessive or abnormal drainage and significant changes in vital signs. Note the number and type of drains when changing the dressing. Examine the incision site. Make sure you use clean gloves and sterile technique if required. Wound dehiscence. This is separation or disruption of a previously joined wound edges, and it may be preceded by a sudden discharge of brown, pink, or clear drainage. Wound evisceration is protrusion of the visceral organs through a wound opening, and this is considered a medical emergency. So you call a code. When drainage occurs on the dressing, the type, amount, color, consistency, and odor of the drainage are noted. Now, wound dehiscence, as again, is just the separation of the wound that was previously closed. Again, you need to notify the physician about that. It's not a medical emergency as wound evisceration. Moving on to psychological function, anxiety and depression may occur in the postoperative period. These states may be more pronounced in the patient who has had radical surgery, an amputation, or whose findings suggest a poor prognosis. And so attention, to the history of individuals who have neurotic or psychotic disorders. The responses may be part of the grief process. Risks with lack of knowledge, assistance, or resources. So there may be an overwhelming, what am I going to do now? And it may be more pronounced, as I've said, in the patient who's had a radical surgery, amputation, or whose findings suggest a poor prognosis. After surgery, confusion or delirium may arise from physiological sources, as we've discussed, so fluid and electrolyte imbalances, hypoxemia, drug effects, sleep deprivation, sensory alterations, deprivation or overload. And don't forget about DTs from alcohol withdrawal. So postoperative alcohol withdrawal is a reaction characterized by restlessness, insomnia, and nightmares, tachycardia, apprehension, confusion and disorientation, irritability, and may have auditory or visual hallucinations. So with respect to psychological function, nurses need to be cognizant of the increasing incidence in delirium, dementia, and depression in the older adult population. So provide adequate support, listen and talk with the client, offer explanations, reassure and encourage involvement of significant others, and discuss expectations of activities and assistance needed after discharge to try and relieve some of that anxiety. Make sure you include the client in any discharge planning and provide the client with information and support to make informed decisions about continuing care. recognize alcohol withdrawal symptoms, and report any unusual behavior for immediate diagnosis and treatment. So we're moving on, and the patient's ready to be discharged. And so the choice of discharge is based on patient acuity, access to follow-up care, and the potential for postoperative complications. So what allows a patient to come out of the PACU and be transferred to the surgical clinical unit? And so it's based on specific criteria. So the PACU discharge criteria, the patient needs to be awake, vital signs stable, no excessive bleeding or drainage, no respiratory depression, O2 sat above 90, and report has been given to the oncoming nurse. What if the patient's in the ambulatory surgery unit and they come in for a same-day surgery? So again, the discharge, all the PACU discharge criteria needs to be met. So all this needs to be met. No IV opioids have been given in the last 30 minutes. There's minimal nausea and vomiting. They have voided. They're able to ambulate if age appropriate and not contraindicated. There's a responsible adult present to accompany the patient, and written discharge instructions have been given and the patient understands them. So when you transfer the patient to the clinical unit, the PACU nurse gives report to the receiving nurse summarizing the operative and the postoperative periods. The receiving nurse assists with the transfer onto the bed. Vital signs are obtained and the patient status compared to the report provided by the PACU nurse. After the transfer, an in-depth assessment is performed by the clinical nurse on the unit, initiation of postoperative orders, and the encouragement of ambulation, as we've discussed before. Ambulatory and inpatient surgery discharge, remember that it's very hard to do all the teaching in such a short time frame. And also remember that the client must be mobile and alert and be able to understand the teaching required. Before they can go home, there needs to be a degree of some type of self-care, that they can get up to the bathroom themselves, they can wash themselves. Pain, nausea, and vomiting must be controlled. They must be at or near their preoperative functioning. Instructions are specific to the type of anesthesia used, and verbal and written directions are given. The client may not drive. Again, they need to be accompanied by a responsible adult, and oftentimes a follow-up phone call is done. It's important to think about the education. So preparation for discharge is an ongoing process throughout the entire surgical experience. You just don't start doing post-op teaching on the day that they're going home. So when you're doing wound care, speak to them about care of the wound site and dressings and bathing recommendations. When you're giving them their medications, explain to them the action and adverse effects of their medications, when and how to take them. Explain to them the activities allowed and which ones are prohibited. And so it gradually allows the client, and also allow the client to gradually assume greater responsibility for self-care during the postoperative period. Speak to them about any dietary restrictions or modifications, which symptoms should be reported, give them any instructions for follow-up care when their follow-up appointments are, and provide any answers to questions or concerns. What you're going to do is you're going to document the discharge instructions. You may be involved in doing the follow-up care or visit, or you may be involved in arranging that with a community caseworker. And you also may be involved working with the discharge planner or the case manager to facilitate a great transition from hospital-based to community-based home care. So just to end up with some final age-related considerations. So remember that our older adults have decreased respiratory function, including decreased ability to cough. They have decreased thoracic compliance, and it places them at a greater risk during the perioperative period. Pneumonia is a common postoperative complication in older adults. And so these alterations in pulmonary status lead to an increased work in ventilation and a decreased ability to readily eliminate pharmacological agents. So you need to be very cautious when you're giving narcotics and sedatives to these patients for that reason. Cardiac function is often compromised. Drug toxicity is a potential problem. Renal and liver function must be carefully assessed in the postoperative phase to prevent drug overdosage and toxicity. Postoperative delirium is very, very common, and pain and PCA use. Be very careful on your use of narcotics and giving an older patient who may be confused a PCA pump. So we can review any further questions that you might have when we speak in our Zoom session.